Now let's begin the final session of day 1, which will focus on gender. This session will be chaired by Dr. Teresa Arun Chaudhary. Dr. Chaudhary is a professor of economics and co-director of Innovation and Technology Center at the Lahore School of Economics. Dr. Chaudhary, please proceed with the session.
So I'd like to call the first speaker of the session to the podium.
So I am Dr. Suresh Park from Health Business Academy, Islamabad, and today I am here to present my research paper on the topic of bridging the gap, women's empowerment as a pathway to reducing out-of-pocket health expenditures, catastrophic health expenditures, and impoverishment in Pakistan. So, it is not working. So, as you all know that the out-of-pocket health expenditures can be defined as the payments that are made directly by the patients to the healthcare providers at the time of service utilization. And these are the direct payments that patients are going to pay to the healthcare providers when insurance does not cover the full cost of health goods and services they are utilizing. These out-of-pocket payments become catastrophic when they are surpassing 40% of the overall financial capacity to pay by the households to cover these costs. And there are different thresholds defined by the researchers for the catastrophic health expenditures. Some are using the 10% threshold level and some are using the 40% threshold level. And there are also different studies who are defining the catastrophic health expenditures. Like some are saying that it can be measured as a larger proportion of the household's budget spent, and some are saying that it can be measured as a household financial capacity to pay their total food consumption minus the food spending. And then what is the impoverishment? The household becomes impoverished when the total consumption, which includes out-of-pocket health expenditures, exceeds the overall poverty line. They become impoverished. And when households have to pay larger amount of their budget on the healthcare needs, then they have less to spend on the basic necessities like food, shelter, and clothing, so they fall into the poverty trap. In low and middle-income countries, the healthcare services are mainly financed through out-of-pocket payments, which are considered as very inefficient, inequitable, and least sustainable way of financing healthcare. Heavy reliance on out-of-pocket payments, specifically in developing countries like Pakistan, where there is poverty and diseases are widely spread, increases the financial burden of households. So this is the graph that is showing the comparison between Pakistan and South Asian countries about the current health expenditures. And here we can see that in Pakistan, the current health expenditures are increasing in the recent years as compared to the other parts of the South Asian countries. The 2030 Sustainable Development Goal also highlighting the importance of having access, importance of everyone having access towards the healthcare services without facing the financial burden. And the goal number 3.8 specifically aims to protect people from experiencing the excessive healthcare expenses and reducing the out-of-pocket healthcare costs. If it is insured, it will not only improve the individual health and well-being, and then also the nation's wealth. So this is the figure that is showing the household expenditures on health, and you can see that in Pakistan, about 1.02% of the households are experiencing the larger expenditures on health. And this is the figure that is showing the out-of-pocket health expenditures, and in Pakistan, about 53.8% of the people are experiencing the out-of-pocket health expenditures. Now, this is the graph that is showing the prevalence of impoverishment in Pakistan, and here you can see that about 21% of the people are at risk of falling into the poverty trap because of facing the payments towards critical care and anesthesia payments. So, these are some statistics from literature. Every year, globally, about 150 million people are facing chronic catastrophe because of the healthcare expenditures, and about 100 million people are pushed into the poverty because of the out-of-pocket expenditures. In the Asian region, the substantial number of the individuals are tapping into the dilemma of high healthcare spending, and most of the people are talking about 10 to 25% of the total income on medical expenses, which is very high. Pakistan, which is a low and middle income country and is the So there are different reasons for it. For example, in Pakistan, about 81% of these costs were incurred in the private sector, and only 90% were incurred in the public health facilities. And we all know that in private facilities, the costs are relatively higher as compared to the public health facilities. Then, according to the National Health Account, only 3% of the Pakistan's GDP is spent on public health, which is very low. PBS is showing that about 10.4% of the total expenditures are related to the health initiatives. Then there is a lack of inequitable and ineffective health financing systems, social protection programs, and health insurance coverages. And then, like the portion of the household, the budget is spent on basic healthcare needs. So they adopt the different coping strategies to cover these costs. For example, they are withdrawing their children from the school and they face problems to afford basic healthcare needs. And then there is another dilemma that despite of the availability of healthcare services at their doorsteps, still they are not utilizing these services, which further deteriorates their health and also reduces the productivity and income of the individuals. This vicious cycle continues, and the poor people becomes more poorer and more deeper into the poverty, and others become the impoverished to the effects of the programs and mechanisms. Then even in the high-income countries, the catastrophic health expenditures do exist, but the impoverishment incidence is high in low and middle-income countries. So now, why women empowerment is important to study in this scenario? We all know that women's empowerment is a potential enabling factor in determining the household resource allocation and healthcare utilization, and they are also serving as a catalyst for improved maternal health care. Literature shows that empowered women can make better decisions in terms of their child health and education, which in turn not only improves the household food and nutrition security, but also elevates the poverty at the national level. Literature shows that the women are contributing about 43% of the agricultural labor force, both globally and in the developing countries, and producing about 50% of the world food. And they also got significant sustainable goal number 5. But and in Pakistan, women are comprising about 48% of the population and about 67% share in the agricultural employment. Still, the women got less significance in Pakistan society, and her status is very low as compared to the men of the society. According to gender inequality index, Pakistan is ranked at 136 out of 162 countries, and according to the gender gap index, it is ranked at 151 out of 153 countries, which shows that these figures are very alarming, and it shows that gender inequality is prevailing in Pakistan. So this is the figure that is showing the prevalence of gender equality, and here we can see that only 20% of gender equality is achieved in Pakistan till now. So the research gap. There are different US studies which explore different kind of factors to assess and the utilization of healthcare services, but no single study focuses on women empowerment in this scenario. Emphasizing the gender equality in health is crucial for sustainable development, necessitating a gender-centric approach. So in this study, we are making women empowerment because we are saying that women with better decision-making power are more likely to prioritize food and nutrition security of their families, and ensuring the better health and better well-being of their families. With the better nutrition and health-conscious decisions, the family members are less likely to fall ill, which leads towards the less instances of sickness within the family. So they have to less incur the healthcare costs, and they have to go for medical treatments. So women empowerment is considered as a pathway of reducing the out-of-pocket health expenditures, catastrophic health expenditures, and provision. But the relationship between women empowerment and healthcare tools remains under-investigated in Pakistan, where there is, which is marked by high mortality ratio and gender disparities. So the specific research objectives, first of all, is to estimate the total household out-of-pocket expenditures, catastrophic expenditures, and provision in Pakistan, and then to estimate the impact of women empowerment in reducing all these expenditures. And then the other contributions. First of all, the present study contributed in developing the Quantified National Women Empowerment Index by using the 9 domains. And then there is the contribution towards the development of relationship between women empowerment and all these factors. And then there is the methodological side contribution by adopting the multi-level mixed effect modeling at different levels in this household and community level, which is not studied before. So data is taken from the Household Integrated Economic Survey, HIES, from 2018 to 19. That was published by the Pakistan Bureau of Statistics. Total 24,800 households were used, and these are distribution and random. This survey includes the household health expenditures of all types of expenditures that they are incurring from both public and private sector. Empowerment index was conducted by using the 9 domains, and principal component analysis was used to develop the index. WHO's per adult equipment scale was used to determine the impoverishment levels. Then multi-level effect logistic modeling was used for the regression. These are the study areas that was used in this study. And then these are the results from factor analysis. As you can see here, that there are 9 domains of women empowerment used for developing the index. And then this index is used to categorize 3 categories of empowerment, that is low, medium, and high empowerment. And these categories are used as key independent variable in the regression analysis. So dependent variable, the first one is the catastrophic health expenditures, and for this we have used some methodology proposed by the Wextoff and Rossler. They use the 10% threshold level to define catastrophic health expenditures. That if the out-of-pocket health expenditures are increasing 10% of the total household capacity to pay, then it means that they are facing the catastrophic health expenditures. For the sensitivity analysis, we are using the different threshold levels like 5%, 15%, and 25%. For impoverishment impact, we measure the poverty headcount of the household, and then we aggregate all the poverty headcounts in a household and compare with the poverty line that was given by the Ministry of Finance in 2018 and 19. It was 3,776 rupees. And then the variable was constructed by assigning the value of the one if the woman falls into poverty, otherwise zero. And these are the results. It is found that women empowerment is a significant factor in lowering the out-of-pocket health expenditures, catastrophic, and impoverishment. By 1 increase in all the 3 empowerment levels, the out-of-pocket health expenditures were reduced by 1.4%, 1.9%, and 1.53% respectively. And it is an interesting result here that even if the women achieve the low empowerment at the household level, still the healthcare expenditures can be lower. Similarly, the same is the case with the catastrophic health expenditures at the 10% level. By increasing the women empowerment, the household expenditures decrease, catastrophic health expenditures decreases by 11%, 21%, and 28% at the household level. And then we can also see the same effect with impoverishment. By 1 unit increase in women empowerment, the impoverishment, that is poverty, decreases by 92% at the household level. So this is the table. Here we can see that in model 1 we are using out-of-pocket health expenditures as the current variable, then catastrophic health expenditures in model number 2, and impoverishment effects in model number 3. And all these are the co-variates used, but our key independent variable is the women empowerment, and you can see that it is a negative and significant relationship with the dependent variables, as I explained earlier. So, concluding is that out-of-pocket health payments exert pressure on households and push them into the poverty. And then the article recommends that burden of out-of-pocket expenditures can be lowered if the women get empowerment at the household level, and we can save them from falling into the poverty. Policies and programs should be aimed by considering all women with more focus on those women who are belonging to the less well-quantified and who have poor education or low education. So there are different existing policies in Pakistan, but in these policies, women's role is missing. Women are not involved in decision making. Policies are not built on international grounds. No gender marker checklist in Pakistan which can compare the gender equality at the same level. And then there are governance issues in Pakistan. Sustainability and consent of all stakeholders are also missing by devising the policies. So what should be done by devising the policies? One key idea is that bringing together all sectors and policymakers from all venues by devising and designing the policies. And then the resulting policies will be effective, focused, and the long term. So our goal is to incorporate women's role by devising these policies, and efforts should be documented on international grounds. Thank you.
I'm going to discuss another industry does not spend enough of its GDP on public health expenditures, and a lot in the public sector is not providing a lot of the care. A lot of people are moving towards the private sectors. Out-of-pocket health expenditures are high. Health insurance is hard to obtain. There are some programs for low-income people that have tried to reach the poorest of the poor, but it's hard even when healthcare is free to them. Such as there was a program that was started a few years ago in KP, and it was hard to just inform people that they had free access to health facilities, both public and private. So even when that cost issue is resolved for them, it's not necessarily automatic that people are going to avail themselves of these services. But so then Dr. Sudra brings in the role of women's empowerment. So from the literature review that she cited, she was talking about how empowerment would lead women to seek education, employment, and have a greater demand for nutrition and maternal health care, and that would lead to greater health care utilization. She also talked about how empowerment would lead women to have greater control over household financial resources, and that could also lead to more spending on health. But then after that, she talks about that women's empowerment can play a role in reducing out-of-pocket expenditures and catastrophic expenditures, which would entail lower expenditures on health. So there's a bit of a jump there from talking about how empowerment would lead to greater healthcare utilization to empowerment leading to less healthcare expenditures. So there's a little bit of a gap in that narrative. Later on, she does bring up that preventative care can help to reduce catastrophic expenditures. So I would definitely encourage bringing that part of the story up into the introduction and the literature review, so that we have a tighter connection between how one can propose or hypothesize that empowerment would lead to reduced healthcare expenditures. And then also one might also want to think about the direction of causality here, because if someone has if the household is not spending very much on health care, then that can lead to poorer health on the part of the members of the household, particularly the women. If household resources are not going towards prenatal care, maternal health care, delivery services, which could lead to reductions in women's empowerment if they are suffering from poor health. So the direction of causality, one might want to think about here. Now, some of my sort of key questions and concerns. So first, I just want to start with some of those. So with the women's empowerment variable, is developed first as a continuous variable, but then for the purpose of the analysis, it's broken down into 3 categories: low, medium, and high empowerment. But then in the regression, so we get estimates for all 3 levels of empowerment. So I was a little bit confused how the dummy variable trap wasn't encountered there, why one of those categories wasn't dropped, because when it comes to measuring the effect of different levels of empowerment on healthcare expenditures, it would always have to be relative to an excluded category. So I'm wondering where the excluded category was, if there was something in the paper that I missed and that there was actually an excluded category. If there was not an excluded category, I would suggest to look at the coding of the variable and make sure that there weren't any missing variable data, that there wasn't any that there weren't any responses that were missing that weren't that weren't recoded to missing, so that those observations were dropped. The same issue for the inpatient versus outpatient variable and the public versus private. I did not see an excluded category for either of those categorical variables. Now, the next issue that I wanted to highlight is that household wealth seems to be missing as an important variable, because households that have greater wealth, women will be have greater status in the household, and they will also be able to afford health expenditures and have them not be catastrophic. So I would say that household wealth is an important variable that's omitted in this analysis. So I had some other questions about the measurement of the empowerment variable, which I can share with the author more directly, and the choice of the estimation technique. But what I would say is, just in terms of my suggestions for moving forward with this paper, if you want to stay with the empowerment connection to health expenditures, I would say that you want to have a tighter narrative tying women's empowerment to health expenditures. So if it's through better preventative health, I would say, why don't you try to measure some correlations between women's empowerment and and access to and the usage of preventative services, because the data, I know this is very small, I can't really see it. The data that's collected by the HIAS is actually pretty detailed. So the kind of whether someone's gone in for an accident, whether they've gone in for a chronic illness, whether they've gone in for preventative care, all that data is there. So one could look at correlations between the empowerment and the seeking of preventative care. That would be very useful. And just because empowerment and because the empowerment data is being collected at the same time as the health knowledge information, as the health expenditure information, then it's always going to be difficult to establish a causal relationship. But the correlations will still be interesting, and one would just have to interpret the results in that light. Now, other directions that one might take would be to look at health knowledge and the kinds of care that people try to access. So, for instance, there has been some recent work, very, very recent work in Pakistan, just looking at the kinds of healthcare utilization that poor households try to access, and their knowledge about the efficacy of different kinds of providers and their understanding of the cost of accessing those treatments and how that affects their choices of trying to access healthcare. And so an interesting, and within that study, they actually asked for expert assessments talking about, for this kind of illness, which kind of facility should you go to? And so they have that information there. And there's also information in the HIAS about people's health knowledge, about whether they know what the symptoms of malaria are, tuberculosis are, hepatitis are. So one could look at some correlations, between people's health choices and their health knowledge, and through this survey, that would be, again, a correlational analysis, but it would be something that would be really interesting to find out. Further, one might look at what kinds of health care turns out to be more catastrophic or impoverishing. So is it maternal care? Because at least one study that I had looked at a while ago was talking about how especially delivery care, cesarean sections are basically very impoverishing, catastrophic health expenditures for poor families. And what other kinds of chronic illnesses are impoverishing? All right. So I guess those are my comments, just some ideas about further research. Thank you so much. All right, thank you. All right, and so now we have Dr. Sadia Batul and our final speaker. Oh, yes, I'm sorry, I forgot the questions. I'm the chair. All right, sorry. Let's move for questions before we move to the last speaker. Sorry about that.
Hi. So I think it's a very interesting paper, and I think it presents some very interesting correlations between women empowerment and how to help expenditure. I think just from the point that Chris already mentioned, I think if you move beyond those correlations, you need to be able to say something about the cause and effect and to also address the problems of the reverse causality. I think that's something which we can work on, and I think we can start with some things. For instance, I would suggest that we could look at the lag effect. So the women empowerment 3 years ago, what's the effect 3 years And then I think also the part where there are so many other encounters that are there. So I think that you can, I would suggest that instead of taking the whole women empowerment as one thing, you could probably take some particular thing within that environment and then look for either some experiment that's already been done to experimentally change that, like if it's education or if it's like access to maybe better health services, some vaccination cap or anything like that, right, which is being experimentally changed, then you can take that and then you look at your measure using your data of out-of-pocket health expenditure and see what's the effect of that. Or you could look for some shock in that one thing that you take instead of taking the whole women empowerment thing as a whole. So that would be better. And I think also in terms of the narrative, so you started off with saying that this out-of-health expenditure is like a bad problem, and then it's a global problem, and then you move on to this, how does that relate with women empowerment? So I think that narrative of, so you start by presenting out-of-health expenditure as a problem, and then you start by investigating the relationship with women empowerment, just seeing their positive good, right? That needs to be a bit more fleshed out and very set up as to what's the motivation for investigating this particular relationship.
One thing I've observed is that the woman empowerment is not linearly related to out-of-pocket expenses. For example, your coefficient for, if I'm not mistaken, the low empowerment was 1.4, which increased to 1.9 for medium empowerment, but again decreased for high empowerment. Do we have any explanation for that?
Maybe you will take all the comments, research comments on the and answer.
Any other questions before Dr. Sidra adds her responses?
So starting from so I just made 3 categories from that index, and it is not a binary variable. It has 3 different categories, and I used the ordered logistic regression in that one. So I got every value from each category in the regression analysis. So it is, first of all, it is not continuous, and you are saying that how the higher empowerment is lower as compared to the low one. So these are just results, and I don't have just for justification for that, but these are the results from statistical analysis, and it is enough that it has analytic and statistical relationship with the dependent variable, and we are getting lower, likely to get lower expenditures by empowering women. So thank you for the suggestions. I will incorporate all your suggestions in my paper, and I have noted down these ones. Then 12 index is not omitted. I used that one, but I used instead of 12 index, I used the income variable in that analysis. So as a proxy for the 12 index, so it covers that one. And then I will make the causalities, reverse causality, and the correlations that you suggested me. And thank you for your suggestions.
Okay, so can we move to our last speaker, Dr. Sadia?
So quality teaching has been widely associated with strong sense of teacher efficacy, as those possessing it are usually committed to teaching, and those who are not possessing it, they may not be that good in teaching their students. So it is said that teachers who are efficacious, they are more punctual, they can manage their classrooms well, they individualized teaching methodologies, differentiated instructions, and they can also manage the challenging behavior in their classroom. Similarly, they can use varied evaluation strategies. Then quality teaching is usually dependent on the use of effective outcomes in teaching to making learning more relevant, motivating, rewarding, and hence permanent. So effective outcomes here means effective domain is one of the domains of Bloom's taxonomy. It says that if you bring the students' emotions into the classroom, if you utilize their emotions in learning process, so the learning will be long lasting. It would stay with students for a longer period of time. Then theoretically, teachers who make successful use of effective outcomes in teaching are more likely towards strong self-efficacy beliefs. But this is something which is not being tested. So this study is testing this belief, but theory says this. So as effective domain is not just a simple catalyst, but a necessary condition for learning to occur. So most of the people say that if you want learning to be permanent, if you want learning to be long-lasting, you should inspire the students and you should use their emotions, their feelings, and you should cultivate such feelings in them that they may be inspired, and the learning in that case would be long-lasting. So self-efficacy, which was the concept which was actually introduced by Bandura, which was later then converted into teacher efficacy. So self-efficacy can act as a catalyst or an anti-catalyst. So it depends upon how the person or how the teacher uses it. So if you are efficacious, then the efficacy would be the catalyst, and if you are not an efficacious teacher, so you may spend all in teaching, but the students will not be able to get from your teaching. So teacher efficacy can be explained in terms of the three factors, that is student engagement, then instructional strategies, and classroom management. So these are the three factors which are utilized for evaluating the questionnaire for this study, and this questionnaire was developed by Christian Moran and Woodford Poem. It is also known as TSCS. So what is student engagement means? You should keep the students engaged in the classroom. They should not be free, they should always be busy in learning, they should be creative, and it is not that you should burdenize them, rather the task should be involving them in critical thinking, engaging them in different projects, in different activities which are of their interest. Then instructional strategies, you should be able, being teacher, you should be able to use differentiated instruction. You should be able to visualize instructional strategies. Means if there are different kinds of students in the classroom, so you cannot utilize the same strategy for teaching all the students. So if you are utilizing differentiated instruction or individualized instruction, so the instruction will be better than the classroom management. So the teachers who are efficacious, they can easily handle challenging students, and they are confident about handling the difficult situations that may arise in the classroom, sometimes suddenly. So these are also the soft skills. So then Bandura in 1997, she was the one who developed the teacher efficacy, gave the concept of self-efficacy. So there were 4 foundations she mentioned: mastery experiences, vicarious experiences, social or verbal persuasion, and emotional and physiological states. So mastery experiences are the experiences that if you are successful, so you would try to achieve more success. So this is the taste of success that makes you achieve more and more success in the future. So then our vicarious experiences. Vicarious experiences are that you learn from the experiences of other people. If some teacher performs good, so you try to copy and you try to imitate that teacher. Even in our life, we used to do this thing, and this social and verbal persuasion. So when you do something good, people appreciate you. So that appreciation is also required for being more efficacious. That emotional and physical physiological state. If all other things are available, but you are emotionally or physiologically, you are not in a proper state, so that things will be useless. Then these are the research questions. You may not find answer of some of the research questions because this study is in process. So the research seeks to answer the following research question: is there a difference between male and female teachers' efficacy? Then the second question is there a difference between male and female teachers' use of effective outcomes in teaching? Does the effect of using effective outcomes in teaching mediate the relationship between gender and teacher efficacy? So these are the research questions. So it is a quantitative correlational study, and sample encompassed 750 teachers, out of which 342 were women and 408 were men between 17 and 63 years of age, with a mean age of 33.7 4 years for women and a mean age of 34.94 years for men. So teacher sense of self-efficacy scale is based on the sub-scales which were prepared, and it was prepared as it is also previously being said that it was prepared by Anita Wilfer and Deshan Goran. Then teachers' use of effective outcomes scale items were developed based on Pritho's 5 categories of objectives in the effective domain. So it was a self-developed questionnaire. So in the economics, like you take secondary data, but in education and psychology, we usually rely on primary data. So the Shipoli test was conducted to determine the normality of the data, whereas parametric data was analyzed using the paired sample t-test, and non-parametric data was analyzed using the Wilson sign-train test. Skewness and kurtosis for each variable also demonstrated appropriate normality. So these are the results. So results showed that there was a significant difference between teacher efficacy, that T was 739 is equal to 9.296, and the D difference is equal to 0.68. The scores of male and female teachers in the sample, it means that there is a significant difference between the efficacy in the teacher efficacy of male and female teachers, and these differences were also visible in their strategies of student engagement, instructional strategies, and classroom management strategies. So results also showed that there was a difference between the use of effective outcomes in teaching, scores of male and female teachers in the sample. There was also a significant difference between the male and female teacher scores related to use of receiving, responding, organizing, and characterization of the value complex. These are the derivatives of these are the points or the categories of the effective domain. The first is receiving, that is responding, that is valuing, organizing, and characterization of value complex. So these are some of the implications of this study. So inclusive learning environment. Teachers should create inclusive learning environments. Means that the inclusivity is the beauty of the classroom. So if there are different students in the classroom, so teachers should not be worried about that, but they should cater for the individuality of the students. Then tailored assessments and interventions. So assessment should be tailored, means like between teachers we have the same assessment for 50 students or 80 students in the class, but we do not cater for individual differences. So we should keep this thing in mind, that interventions and assessments should be tailored. Then ongoing professional development. Somebody in paper he was also talking about professional development. So professional development is very much required. People who have studied 10 also be involved in the teaching learning process. Most of the parents will stay away from their children education, and the entire responsibility resides, they think that entire responsibility resides in the school. So this should not be the approach. Then strength. Strength-based focus means we should not, strength-based focus means we should not focus on the weaknesses of students, rather, which is called X factor. We should find out what is the strength of the student, and we should utilize those strengths in teaching our students. Then the same participate feedback and reflection. So being teachers, like we involve the students in the examination, and we keep results with ourselves and do not announce the results. We do not tell the students. What psychology says that immediate feedback is necessary. If the feedback is not immediate, then students will lose interest in whatever you are going to and how you are going to evaluate them. So immediate feedback is important, and you should, like in papers, in our evaluation sheets, we do not write remarks. So we should write remarks about the performance of students, and that the remarks should be very much typical and very much specific to the performance of students. So thank you very much.
Okay, so I think some wires had gotten crossed, and so the discussant received a different paper, didn't get the right paper in time to be able to write any comments. So we are going to jump right into the Q&A. But also, I just have a question as, you know, as an economist, not an education researcher, or who has a lot of background in this kind of psychosocial analysis. If you could tell us a little bit more about what about, you know, these different scales that you use in the data, like for instance, like the teacher's use of affective outcome scale. Could you tell us a little bit more about like what those scales, what those tests measure, like what the components are, and like what they're trying to capture? Just because, you know, since most of us are not super familiar with that stuff, we would be able to understand or get more out of your paper if we understood those measures a little bit better. And that's just my question, and I think we have some more questions here.
Hi, thank you for the presentation. It's a very interesting approach. I have a couple of questions. So firstly, I think most of your analysis is based on what's the relation between male and female teachers. I'm curious if you've done analysis on any other factors, such as the teacher's academic background, their professional background, and if that has an impact on their self-efficacy. Secondly, does it matter at what level are those teachers teaching? Because I would imagine somebody who's teaching at a primary school level would teach very differently versus at an undergrad level. And if you've explored how the teacher's teaching actually is being perceived by the students, and if there's any impact on student learning outcomes because of this variation.
Just to add to that as well, again, I found this very fascinating. Just to understand, what are your insights on the difference between male and female? So one could be, as I said, different levels, but also are there also differences by subject and what they're teaching? And what could be the reason for this gender difference? Are there social and emotive reasons behind why men may be more effective in something and women in the other? So just trying to understand in a bit more detail. Thank you.
all the three sub parts of it, and each part was having its own number of questions. The second questionnaire was developed. It was a self-developed questionnaire which was developed by using Crefro's 5 category objectives. It is a theory which is given by Crefro, and the scale was developed by using that theory, and then the validity and reliability of the scales are also tested. And for the first one, the CFA, confirmatory factor analysis, was also used. So then is the question is about demographic variables. Just the studies conducted at secondary level. I have not conducted a study for all levels. So this was secondary level. So secondary level here in Pakistan is 9th and 10th classes. So the teachers who are teaching 9th and 10th classes. So their data was taken from them. Then again the other variables they will also be correlated in the study. So then thank you for your suggestion. I was thinking about the same thing. So the last question was about gender differences. So one of and the reason for such gender differences. So one of the things that was found that females have higher teacher efficacy, and the reason found behind this, or it was found that because in Pakistan, due to the cultural you can say requirements, it's a cultural compulsion that teaching is considered as teaching, especially at school, is considered as a female thing. So female teachers, they used to, like, it's not a culture in big cities, but in towns and in villages. So women prefer to be teachers, and their family allow them to go for teaching. So they work hard and they try to make their name in teaching, so their efficacy used to be high. So similarly, about effect was asked, there's been women are more sensitive towards the children needs. So that's why it is recommended that at primary level, at the pre-primary level, the teachers should be females, because they are more nurturing nature. Women choose to be better teachers at pre-primary and primary level. So their effective outcomes are also mostly in the favor of female teachers. But it was found that male, they are more social, and that's why on the social side, effective domain was almost equal for male and female teachers.
Okay, so I think that concludes today's final session. I don't